So, by way of discussion, what does all this data mean? On this slide, we have presented a forest plot which I've drawn up with all the trials previously mentioned. Notice that the left favors ARB and the right favoring placebo or ACE inhibitors. The hazard ratios and p-values described also on the right. Notice that the 95 confidence intervals for every single trial falls on the equipoise line. Note specifically the on-target trial, remembering that n is equal to nearly 26,000, has an unadjusted hazard ratio of 0.98 with statistical significance. I submit to you that this is the greatest evidence that ARB is as effective as, but not superior to ACE inhibitors in the treatment of CHF. This conclusion is reinforced by a recent pooled meta-analysis by Shibata et al. Looking at most but not all of the trials mentioned. The author found that there was no statistically significant effect or improvement of mortality for ARB versus ARB and ACE inhibitor combination therapy, or ARB versus ACE inhibitor monotherapy. So, in summary, ARB are as effective as ACE inhibitors in the improvement of morbidity and mortality in CHF. However, ACE inhibitors remain to be the frontline agent used. Survival has been shown with ARB monotherapy versus placebo. However, the superiority of ARB over ACE inhibitors has clearly not yet been demonstrated. And in fact, from the studies I investigated, we found that combination therapy actually yielded a higher incidence of adverse effect, specifically hypotension and decreased renal function. Thus, it could be hypothesized that the maximum protection provided by an angiotensin II blockade could be with ACE inhibitor or ARB monotherapy alone. And indeed, the Canadian and American Heart Associations have both recommended the use of ARB if ACE inhibitors are not tolerated in hypertension. Further, the combination therapy is to be avoided unless systolic blood pressure remains uncontrolled on ACE inhibitor therapy alone. So again, in conclusion, ARBs have been shown to reduce mortality and morbidity in heart failure patients. However, ACE inhibitors continue to remain the frontline therapy in AT2 blockade in CHF. Looking ahead to the future, a large clinical trial investigating ARB high and low dosage is soon to be published and may yield some interesting retrospective insight into all the trials I've mentioned. Thank you very much for your time. Okay, does anyone have any questions? Yes.
It sounds like all the trials were negative. Why wouldn't clinicians stick to just ACE inhibitors instead of ARBs?
Okay, again, so the question is, why wouldn't clinicians just stick with ACE inhibitors instead of ARBs? That's an excellent question. I think the results from this literature review show that ARBs are not superior to ACE inhibitors and are generally more well tolerated. 3 of the 5 studies showed that with statistical significance. So there is a small but relevant role for ARBs in those patients who are obviously intolerant in ACE inhibitors. Hospitalization and death by cardiovascular causes has been decreased, so there's a small but significant role for ARBs. Thanks. Anyone else have questions? Anyone? Okay, yeah.
Why do you think the combination therapy didn't work better?
That's a great question. From what I can read from the adverse events, it looked like hypotension was the predominant adverse event, especially if we take a look back here, if I can just pull up this slide back up, at the CHARM added trial. We saw that the combination of an ACE inhibitor and ARB resulted in a high incidence of hypotension and hyperkalemia. So I think the conclusion is that just ACE or ARB monotherapy is probably the optimal amount of peripheral vasodilation and myocardial protective strategy that one could achieve. But it's a great question. I think further research would help elucidate that question. Any other questions today? Anyone? Okay, yep.
Were these trials industry or government funded?
Okay, again, so the question was, were these studies industry or government sponsored? All of the studies were industry sponsored, but I think, which is definitely obviously a weakness, but a strength of that these multinational, multi-center trials is that all the data is fed into independent pooled data analysis, especially, for example, the on-target trial. All the data was not seen by the PIs and the co-PIs until well after enrollment had ended and follow-up had begun. So I think there is obviously the opportunity for author bias in industry-sponsored trials, but I mean, it's kind of six of one, half dozen of the other. Most of these large, impactful trials don't happen without industry sponsorship. I did find about, I think it was 6 or 7 small N equals average of about 300 patient trials, and obviously they're not highly powered enough to show benefits to morbidity and mortality. So a strength and a weakness at the same time. Anyone else? Okay, again, thanks everyone for your time. Thank you.